Welcome back to this session of Dental XP. As you know, it always remains incredibly topical and current. And right now, sitting next to me, I have Dr. Mitsias, who's from Greece. And interesting because I believe it was just 2 weeks ago we had Dr. Kotsakis from Greece, and they both have been involved in the study we talked about, and he's actually here to present that study. It was published in JOMI, and then subsequently some of the case studies we had up in International Journal, Dr. Nevins' journal.
Correct.
Of periodontics and restorative dentistry. And the topic is periodontally mediated bone changing, or we refer to it at different times as socket shielding, root membrane. And it's really, as you've seen, an amazingly current topic. Just recently, we heard it presented by Dr. Gluckman. You presented it at the AO this week, and we were fortunate enough to get you to come by. And so he's going to address that exact topic again, because we believe it may well change the way we contemplate doing dentistry or implant dentistry, particularly in the future. So welcome to be with us. We're looking at collaborating with you more and doing more of the studies, and we're actually involved now in a multi-center study that we're going to do. You've got how many years now on this technique?
We have, I would like to thank you for everything
Cool.
you have done so far, and it's been a pleasure being here. Hospitality is great, and we're very happy to give this lecture on this root membrane topic. As you know, we have the longest data so far published, and we have been doing this for 9 years. We have a 9-year case.
That's amazing.
9 years.
You're looking at data that's cumulatively. We've got a 3-year study, a 5-year study.
We
and then
have we published from 1 to 5 year data at JOMI, and we currently we gave data to San Diego at the of a 3-year study with any rigid implant. We changed the implant to more aggressive one, and we keep on collecting.
it's really exciting. So, will you show us the 9-year case?
Yes, I have it here.
That would be great.
Yeah.
Start ahead and we'll watch and be back with you at the end for question and answer.
Thank you so much.
Hello, dear colleagues. My name is Dr. Mitsias Miltiadis, and I'm coming from Athens, Greece. I have the pleasure to be here on the Dental XP headquarters together with Dr. Garber and his wonderful team. Our topic for today will be the root membrane technique and the long-term results that we have seen and we have published the last 2 years. Our lecture flowchart will start with an introduction, the challenges in implant dentistry, the root membrane technique description, a literature review on this topic, and of course we're going to be seeing a lot of clinical cases. I don't know if you have realized, but we have been drilling for 50 years. There has been 50 years of drilling to the bone, 50 years of placing implants. Since 1965, where Gustav Larsson was the first implant patient treated by P.I. Brennemark, that we owe him so much. 50 years after, we have a lot of challenges that we face every day in implant dentistry. And these are a lot. We are in the era of speaking about minimal invasive and also more efficient implant dentistry. But what does this minimal invasive mean? It means that we want every day to our practice to have less surgery, less trauma, less pain, less complications, and less morbidity. I really don't want to have a lot of vertical incisions or my patients to call me in the night and tell me, doctor, I have this problem and what can I do? I have a pain or this and that. So I really try to be as minimal invasive as possible. Of course, this doesn't mean that whatever we have to do is something that it's more invasive, we will avoid it. On the other hand, we try to be also more and more efficient, which means that we need to be simpler, faster. We always pursue the better aesthetic results. We need also to be more preservative and of course to have a better function. Now, in our everyday practice, we're coming face to face with difficult dilemmas. For example, shall we select a delayed approach or shall we go with an immediate placement approach? Do we have to go with conventional loading versus an immediate loading procedure? Also, shall we go with rejuvenation and predictable guided bone regeneration? Or we can get away and we can have another type of solution like All-on-4 or the use of short and wide implants, for instance. Regarding immediate placement, we know that it works and we're doing this at least 15 years now. Nevertheless, we know the problems that we face with immediate placement and what we have to deal with in order to get away from them. What about molars? Can we always do that? Of course, we can use different type of routes to enter inside and place the implant under some angulation, or we can use here again the wide implants. Then we can have a more centrally based positioned implant placement. We have presented our data at EAO in 2011, and now we do have more than 10 years of results with very good results, I have to admit. On the other hand, the immediate loading concept has been described mainly by Tarnow, but other also excellent scientists, and we know that it has excellent results, especially in the mandible. Initial data showed at least 95% of success rate and survival rate also, and other researchers have given excellent results, even 100%. But is it the same in maxilla? Does it happen the same there? And also in the partially edentulous patients, can you always immediate load with the quality of bone that we're having in the maxilla? It's not the same. What about Malo, Paolo Malo, or short implants? All-on-4, are we in favor of this? Can you always do that? Can you have this angulation of implant placement? Not so easy. Or you can get away with the use of short and wide implants. And here you can see the animation and also the use of the wide and short implants when you have anatomical limitations, instead of using an all-on-4 situation, which is good, but personally I prefer the use of short implants. Here you can see also the X-ray indicating the result. But what do we need to consider in implant dentistry today? Three main things: the prosthetics, crown occlusion, surgery, the implant fixture and the surrounding bone, and of course the maintenance. So much important. The connection and the transgingival gingiva that will give us a long-term result. What about crown occlusion? Can you always provide to your patients a picture like this? Personally, myself, I cannot do this every day. So I'm trying as much as possible to give the best prosthetics as possible, but it's not an everyday phenomenon. And your ceramist, your technician can always provide you with lab work like this? Or can you, as a scientist, as a dentist, can you provide to your patients an occlusal scheme like this that you can see on the right side of the screen? What about the maintenance, the connection and the transgingival tissue? And I'm referring to this because that's of great importance. As you know, on teeth, we do have the cementum and the periodontal ligament. This is the secret of the natural teeth beauty and functional maintenance that we see in the teeth. On the other hand, when we're talking about the osseointegrated implants, we see that there is no cementum and there is no periodontal ligament. So which means that there's a lack of blood supply, lack of tissue attachment, and also there is a gradual degradation of peri-implant tissue, and it's very difficult to maintain the tissue integrity, as you can see here on the screen. Now we have to refer to Nozawa's observation regarding the marginal gingival change. And here you can see the height over the width, the 1/1.5, that we need to keep it. It's very difficult sometimes to have this ratio, and that's why the buccal plate has this type of reduction. As you can see here, the buccal plate, when we place the implants, we think that everything is going to be fine. But as the time passes, and I'm sure that everybody, you have seen this in your clinical practice, you see that the bone gradually decreases and it goes down and down and further down. And then you have this piece of metal showing through your gingiva. And then the patient comes and asks you, "Hey doctor, I did everything correct. Why this doesn't look the same? What have I done and what's wrong?" So this is the answer to this. The V over H. That has changed, the biologic ratio of supra-implant mucosa. And here you can see the difference. So if you can use an implant that has even a smaller neck and you can be more minimal invasive in your osteotomy, this will help you a lot. Now on the other hand, regarding periodontal ligament, loss of blood supply that's derived from PDL has been identified as a major etiologic factor for ridge resorption, as we have seen here from Kotsakis. George Kotsakis is a good friend and a great researcher that has been published in JOMI 2014. Also regarding the ridge preservation techniques, they limit, but they do not counter ridge resorption. Now what about surgery? We've seen great surgery here and there in different meetings and different symposiums, but is this applied to all of us? Can we all do such a great surgery? Or in simple cases like this, for example, that you have some bone and you can place your implant and then you can do kind of predictable GBR. Can all of us do this? And what's going on in even harder cases? How well trained are you and how can you do this in your everyday practice? Look at this case and look at the deficiency of the bone. Can you always do this grafting and take a block and put it there and put some other GBRs and other bone there and then do some periosteal suture, some connective tissue graft and suture it all over? It gets complicated, so it's not so easy. Or how oftenly can you have these extended ridge like Welly Grunder has been described since 2005, that they look like an aircraft carrier. Personally, in Greece, we don't see this a lot, and it's a very big problem. So what's the story behind the root membrane? What is the root membrane? What is the mechanism behind it? Does it work? And how does this happen? It all starts from the roots emergence concept that has been utilized for over 40 years to ensure the hard and consequently soft tissue dimensional stability. We know that has been published extensively. Here's an example by the Salamas and the Atlanta team, Garber, etc. in 2007. No functional benefit, as the area can only be utilized as a pontic Of course, there is preservation of the periodontium, hard and soft tissue, dimensional stability. Another name of the root membrane is the PDL-mediated implant placement. This novel concept relies on the preservation of the remaining root, which keeps the PDL. Of course, it's a flapless technique, and the PDL maintains the buccal plate. And because the buccal plate is intact and it's there, and it hasn't changed, and because there is no extraction, you have the facial soft tissue aesthetics that you want. And that's the main goal. Here you can see the drawing. Now we published on this and we gave indications and contraindications. Our indications and contraindications here you can see is to do the technique on patients with good general health and high level of oral hygiene. You can do the technique on teeth with poor prognosis, big carious lesions, horizontal fractured teeth up to bone level. The technique cannot be applied on periodontal teeth. You don't need any movement, any mobility. At least in my hands, the technique doesn't work. You should do it not in the vertical fractured teeth. I know that there has been literature, especially from Kürzeler in 2013, I think, that has some examples of vertical, but in my hands, so far, I didn't have the results that I wish. No periodontally compromised teeth, no teeth with acute inflammation. You will see later on some examples that we did on chronic inflammation. We had no problem at all. But when there's an acute inflammation, we do not suggest. For us, is a contraindication. Now, you see the scheme here that we published in 2015 in IJPRD. You can see that we drill through the root. We pass the root and we go 2-3 millimeters more apically. That's very important. The root is your guide. You use the root as a guide. And then you do your implant placement that we know from immediate placement. You try to be palatal, and that's your final result, or at least how it has to be done. What about the literature review on this topic? When we did Medline search, at least these days, for socket seal, we found 7 results. And instead of the Kürzeler's paper, that we thank him so much for the great work that he has done on this specific subject, and being the first also to describe a similar technique like ours in 2010, we saw also Kahn's article there and some other case reports, but not something with long-term data or something more than a case report. And when we placed the root membrane technique, we saw only 3 results, and from these, the 2 were our paper with the long-term results and the step-by-step description. Now, histology, the only paper that exists so far is by Markus Kürzeler. I would like to thank him for this, because it's a blessing for us and my team, because he's the only one that he has given this great histological result. And here you can see the PDL, and you can see that he named this space between the implant thread and the root as new cementum. So we accept this, of course, and we thank him again about his great research that he has done. And that's the proof of principle that the technique works, because I know that whenever I give this lecture, everybody asks, and of course this is natural, physiologic, what's going on between the implant thread and the root? Is this being filled with something, fibrous tissue, bone, or so? Dr. Kürzeler named this as new cementum. We published also, as we said, in IJPRD with the step-by-step description, and also in JOMI with together with Dr. Shorbas that he invented the technique, and I first saw it in his hands in 2006. And you will see later on that a case that he did, our team, from 2006 until now, that it's 9 years old. It's the oldest case that I've ever seen, with great result. And we published in JOMI together with Garber and Kochakis. Now, the radiographic examination revealed good crestal bone stability with mean crestal bone loss on the mesial and distal aspects respectively of the implants, estimated to be of 0.18 plus minus 0.09 millimeters and 0.21 plus minus 0.09 millimeters respectively. The only complicated noted the complication in this in a patient cohort was apical root resorption in one single retained root fragment that did not interfere with disintegration of the implant. On the contrary, bone went there and it filled up the space. Here you can see a single incident of root resorption. Here you can see with the arrows how this got better, and the CAT scan that showed in the initial placement and how we got better after some time. We had no subjective symptoms, uncompromised implant and restoration function. This was considered a failure under strict success criteria, but we included it in all our studies and still in function. In our study, we had one implant site per patient. The number was 46 patients. The mean follow-up was plus minus standard deviation 44.9 plus minus 5.7 months. All implants were immediately non-functionally loaded, and they found to be clinically stable at subsequent evaluations. Here you can see a case on the right. You will see it later on with the PDL there and the implant placement below. Final loading was performed with fixed prosthesis, and all restorations functionally survived throughout the follow-ups. As we said about the crestal bone loss, these are the numbers, mesially and distally, respectively. Now, we follow the implant placement, the immediate implant placement that we all try to be on the palatal side, and as you see here, the direction. So how we do it, we use the root of the implant, we pass through as you saw before, and we try to increase our, try to avoid this, as the animation shows, to go more bacal. On the contrary, we try to be on the palatal side. Now here you can see a video, old video actually, that how we're doing the technique. We increase the osteotomy, dentinotomy as I call it, and you use your normal drills. You go from 2 millimeters to 2.8 or 2.5, doesn't matter the company, doesn't matter the implant also. You increase to 3.5, and then you remove the, after you do your vertical cuts, you remove the palatal fragment. We still try to use stock abutments and metal type of abutments because we try to have the technique as an inexpensive technique. Now let's see some clinical cases that we can share. This is clinical case 1 that you see placement here long time ago, and you see the root, how we kept it. Stock abutment, we're trying to make the technique as inexpensive as possible. We live in a world with financial problems, so we don't want to make it as expensive as possible. We want the technique to be able to be used by everyone. So you see here the implant placement before and after the x-ray. You see the PA here, and the root fragment retained. Here you see the CAT scan, PA in magnification, and the final result. And here you can see the final result. I think that this type of papilla is pretty good and pretty acceptable, and I'm very happy with a case like that, especially when it's a case that we haven't done any GBR, we haven't used any biomaterial, and there's no soft tissue grafting, nothing, not even suturing. And here you can see 2007, 2008, 2013, long-term data, how it looks, also the buccal side. Look at this picture, how nice it looks. As you see, our photography has improved throughout the years. And this is a 9 years case. 9 years. Next year I will show it. I promise to Dr. Garber that I will bring you the 10-year data. This is the longest case we ever had, and as you see, the papillae here, they're pretty good and stable. Now another case, a lateral that has to be removed. We did the case here. Patient didn't want to change this also, but we did it only for this. We removed the palatal part, we did the osteotomy, dentinotomy, and we placed the implant, as you see, here. As I told you, we use stock abutment. We don't use something special, we try to make it as inexpensive as possible. We try to do the technique with chair side provisional. This is a chair side provisional from my own hands, and the final restoration that we use PFM, nothing special, no zirconia, no lithium disilicate, no nothing. And here you can see the CAT scan, how it looks after the implant placement, and the bone that's stable. Look at the root here. And the panorex after the implant placement. And here you can see some PAs after the placement. You see how the bone is stable here, very stable. And the implant placement, the CAT scan that indicates that the implant placement is correct. Another case, old case, look at this fracture. I'm sure that you can realize that if you remove these tooth, you're going to be face to face with the devil. You will have here to do at least one GBR, maybe two hard tissue grafting, and you may have to do 1 or 2 connective tissue grafts in order to bring back the case and to make the papilla as you wish. On the other hand, here you see that we removed this fractured clinical part and we did our technique. We placed our implant. Here you can see in magnification how the root came here, broke up. Then we even used, for the endo, removed the nerve. And here you see, after the osteotomy, dentinotomy, how it looked. They used the Eneridge implant, the blue implant, the new one with the XP surface. And we try, as I told you, to be not in contact with the root. Here you see the implant placement, nicely done, the root. And in this case, we used a custom abutment, but standard CCM chrome cobalt abutment. And here you see the CAT scan. And look at this. This is from the drill, empty space here. And look at this as the time passes. This is closing up, and this becomes better and better. And here you can see the result. See the before and after, and look at the implant, and look final result as it was. Another one, similar situation. That's an old case, actually, with the previous type of implant we were using, and before the AnyReach, that it's an aggressive type of implant. But it doesn't matter, as I told you, it doesn't matter. Since you can get initial stability of more than 30 newtons, and you can have it non-functionally loaded with your provisional, either it's a chairside provisional or a lab provisional, it doesn't matter. Here you see the tissue that we have achieved. Look at this, stock abutment, but look at the tissue that we have achieved. I repeat, we don't do any GBR, we do not do any soft tissue grafting or enhancing the tissue. We do nothing, just the technique. And here you see previous type of implant, less aggressive, 2008, how it looks, 2014. Color is different because the camera is different, we improved a little bit our photography, and you can see how these papillas look, and that is even better. Now, I would like to report to you for the first time a single incident case that we had with open flap surgery. I know that it's a little bit awkward, but I have to report this to you. It's only one case, and I would like to share it with all of you. This is a patient that came to us like that, and we decided to remove the tooth. We did not decide to do the technique at that point, but we removed the crown, and then we found that the tooth was ankylotic, and we opened the flap because we wanted to do this in order to remove the root part. But when we opened the flap, we came face to face with this type of situation. So I said, and I asked the patient, can we try to do our technique here? And we don't promise for the result because our technique is a flapless technique, and here you have an open flap situation and the blood supply is kind of compromised, but can we try? So we got her permission, and instead of removing this root, we prepared the root. And as you see here, we started to drill inside the root and to increase the diameter of the root. Slowly, slowly, we increased the diameter of the root. The root was ankylotic, and as you understand, that's the best case for us. And because it's not moving at all, so we can easily drill inside. And sometimes drilling, inside the root, it's not so easy. It's harder than the bone, so you need to be a little bit careful. So we increased our diameter, and we increased it even more. And then, when you finish with your dentinotomy, as we said, we went to the proximals. And with the standard diamond, we cut the distal and the mesial surfaces. And you can see it here also. The cut that we're doing, simple cut. Lately, we're trying to be not so 180 degrees, but we're trying to bring the cuts a little bit more, so the root, we keep it a a little bit more, like 200 degrees. And as you see here, here's the cut, and the other one is here. And then we remove the root. Now, I have to say something at this point that this part of the root, the palatal part of the root, if you have done the procedure correctly, it must be removed easily. If the root cannot be removed easily, it means, for me at least, that there is something wrong. And here you can see with the implant placement, this is the first EnerReach implant came as a pilot to our hands, and this is the RBM surface, not with XSpeed or something fancy. This is RBM, this is 2010, dear colleagues. And we did the implant placement. You see here that now we would have treated a little bit more the root surface better, maybe bevel it with red diamond a little bit. At that time, we were still doing cases and learning also, and we still learn every day and day by day from our own mistakes. We did the implant placement, stock abutment. We were not prepared to do this at that time, actually, because the patient was coming from 150 kilometers, 100 miles away from our practice. So we just placed the abutment that we had available at that time. And of course, we did the suturing, just 2 silk sutures and a provisional that we placed at that time. And look at this. This is the result we had 3 months after. 3 months after, that's how the tissue looked. And look at this. Very, very nice scallop tissue. That's the tooth. We decided to do a crown here. And that's how it looks after the implant placement, 3 months after. And this is the impression coping, stock impression coping, nothing special. Just a preparation for a single PFM crown with the cord around it. Look at the tissue, how nicely it looks. And this is the lab work that came from Michael Papastamos. I would like to thank him for his nice job. And here you see, this is everyday work, PFM. It's basic alloy, the cheapest you can go. And I would like to reinforce this point because it's very important if you can achieve nice results or great results, not by using something that is super expensive. So here's a screw retained restoration with a standard PFM next to it. It's like doing dentistry in undergrad. And you will see later on another case that you don't have to worry about papillas. Papilla is there waiting for you just to do a restoration. And here you see the occlusal surface of the 2 single crowns, the cast. And the try-in in the mouth, this is how it looked. At that time, look at this point. And when we place the crowns, you see here again how it looks in the mouth. The 2 crowns, look at the tissue we have achieved. Look at this. I find this exciting. And that's the PFM work by our lab. Simple work, nothing extensive, nothing super precious, nothing special. But it can look special even if it's a PFM, a good PFM. And this is at the day of installation. This is at the day of placement. And as you see, it looks very nice. Here you can see the occlusal surface, how it looks. And that's the smile of the patient. I'm pretty happy with this kind of result, to be honest. I have this papilla, I have this papilla, I have this papilla, and remember, this was an open flap. So, and if you ask me, is this working? Did it last? For how long it's working? I have news for you. 5 years after the same patient with this open flap case and with this simple RBM implant at that time, it looks like that. It looks the same. She has no problems, no complication. She's so happy that I told her, let me see. You said, no, it's very nice and I'm so happy. Don't touch it anymore. It's very nice. I finished with this. So this is how it looks 5 years after. Our results so far, we have made throughout these 9 years 208 cases. I'm reporting to you for the first time. The period of implant placements was from late 2006, 2007 until now that we're still doing the technique. You can see our numbers, 85 and 95, 97, a female and male, and a mean age of almost 50 years. A follow-up period of 6 months to 108 months. And the success rate that we have so far is like 97%. We have 1 implant per patient for 181 cases, upper and lower. 2 implants per patient, 9 cases. 4 implants per patient, 1 I'm going to show it to you now as a last case. And we have 1 case that is multiple implants, and we have 5 of them still working on it. A total is of 2008, 5 of them failed. And from these 5, the one was a bad case selection, wrong case selection, I think, because the lady was a Brookser. And it turned out later on that she told us that she's a Brookser, and if we knew it from before, we wouldn't have included her inside the study. Now this here you can see implant site, upper and lower, and the number of implants that we have placed in each position from premolar to premolar. Mainly it's from canine to canine, but we have tried it also in some premolars. Personally, I don't like it doing in premolars, but my colleague, Dr. Sherbas, it seems that he likes it and everything works in his hand. So, but I prefer to do it on a single root cases. I know that other colleagues have done it and they tried in premolars or molars with good or bad results. But personally, I believe that the technique should be done only in single root topography. As you see, we tried after slowly to do it on the lower jaw. Also, we have some cases there, not a lot, and we're doing it mainly in canines and some big laterals that there is space there. I'll finish with the 4 adjacent implant case that we have the 6-month data already. And here you can see the patient came with this PFM connected, and we had to remove this. And we removed these connected PFMs, old PFMs. You see how it looks really bad. Post and cores and all of this. And that's how the patient looked. You see that the roots are pretty destroyed, and there is some caries here at this level. Lower, it's good. So we decided to do to be more adventurous, let's say, and to try to do the technique in 4 consecutive teeth from lateral to lateral. And here you see that we penetrated inside and we started doing the job. And the cuts here. And you see this picture that shows the palatal part that is being removed. And here you can see some differentiation slowly in the technique that we try to be better on the root and prepare it a little bit more, like scallop it. From our experience nowadays, you need to scallop a little bit and bevel the technique on this part. And here you can see the drilling also inside. And this is the implant placement. After we did a repeat, the implant should not be touching the root. I try always to avoid the implant to touch the root, because as you understand, especially when you have an aggressive implant, it's very, very easy to over push buccally the root. And if you do this, then you can do the technique because it's compromised. At least when I have situations like that, I'm not doing the technique because I'm afraid that the result will not be the same. So I try to place the implant in the center and then pull it as it goes inside on a more palatal direction, so it's not going to be touching the root. And there should be the empty space there that Marcus Hirzler named it new cementum formation, and things will go well. And here you can see at that day the stock abutments that we used in order to load the case, or at least to do this non-functional loading. And these are the chair-side provisionals that I fixed myself at that time from a key silicone that we did from the patient. As you see, this is normal, standard composite, nothing special. And we left the patient like this. Here you can see the post-op, the CBCT, and you can see the implant placement. The patient had some implants placed before there, and here you see, and that he didn't want to touch them, she didn't want to touch them, so we placed the 4 implants as parallel as possible. And here you can see the post-op CBCT. Here you can see also the CBCT and the root membrane technique, that and the position of the implants that we achieved. Then some time after, we called the patient, and she was not an easy patient, I have to tell you, and she came to us, and we took an impression and we sent it to the lab, and we fabricated lab provisionals in order to enhance a little bit the tissue and to make it look better. As you see, the result is very good. Imagine in this case, if you removed the roots or you did a standard extraction and you had placed 4 implants there, what would happen? I think that the word papilla, you would have forget about it. Well, on the other hand, as you see here, it's super nice, scallop, and in place. And this is how it looked after we removed the provisionals. Look at the width of the bone, the volume that we have, and the tissue that we have here to create our permanent work. You see the implants, the root here and there, and how it looks, this kind of papilla. Look at this. I'm very satisfied with such a result. It's still in the mouth now for 7 months, and we see her every month, and it's really, really good and stable. So after we took our impression, this is how the cast looks. We did not use something special, just stock trays and impression copings, standard components of the copings from the company. And we ordered the technician to create the abutments. In this case, we used chrome cobalt abutments. Nothing expensive, as I told you before. 4 CCM abutments you see in the cast. Here you see the cast. That's the axis of the abutments. We went for a cement retained restoration. Not easy always to have screw retained restoration, but we kept the level of the margins. Here you see the copings in the mouth. You see the level of the margin at the same level of the soft tissue, away from the root as possible. And we did the metal trying. I love this picture. It reminds me undergrad. It's like doing PFM trying when I was in the undergrad. I didn't care about papilla at that time. No, I don't think that somebody from you cared about papilla at that time. Same situation is here. You don't care about the papilla if you have done your work correctly, because the papilla is there. The treasure is there. You keep the PDL, you keep the root, you keep the PDL, you keep the bone, you keep the aesthetics, everything is where, and it works for you. You don't need to do something extra. Biology works for you. Here you can see the PFM trying. You see the volume also here, how we maintained it. And this is the final result, standard PFM crowns at the day of cementation with tampon. And here you see, this is, I believe, 2-3 weeks after we cemented the crowns. This is the last picture I have for the patient, and the patient is really, really happy with the result. I repeat, these are 4 implants, no grafting, no soft tissue grafting, no GBR, nothing, just root membrane technique and CCM abutments and PFM crowns. No ceramic, no zirconia, no lithium disilicate, standard PFM crowns. I will end with the discussion topics that we have. Of course, as you can realize, case selection is very important for the technique, the tooth morphology, the periodontal condition, tooth position, and the root position also plays a vital role. Our surgical considerations, of course, we need to be able to achieve initial stability of at least 35 newtons, otherwise you cannot load it. Instrumentation, it's a big discussion on that. The easiness of the technique. In my hands, I found it easy, but even though after years that we're doing the technique, sometimes it's not so easy. And last, how can we standardize the technique? We had a discussion with Dr. Gaber here and his group. They're doing it on a different way. For example, we keep the root there and we drill inside, as I said before, the root, the dentin, and we penetrate inside the osseous part to 3 millimeters, and we use the root as a guide. On the other hand, the Atlanta team group, they're doing it on a different way, and they first drill a little bit inside and they separate immediately the mesial and distal. So they do the cuts and then they remove the palatal part of the root immediately. Then they're creating their osteotomy. It's not a dentinotomy anymore because there's no root there, it's only the half part, and they drill inside the root, the osseous part, and maybe they prepare the root. For me, in my hands, this, I don't know if it can work because there is no guidance anymore from the root itself. It seems that in the work of, in the hands of Atlanta team, this point of view is better, or it works better in their hands. And also the restorative considerations that we have, the level of the margin of the abutment when we have a cement retained restoration, what you're doing there and where you're putting the level. And with this, I would like to thank you so much for being here and for having the opportunity to make this lecture and describing this technique. Thank you so much. And that's the picture of Parthenon, the Acropolis, that it's in Athens. Thank you so much.